manage. So anyway, at the beginning of the talk, I express my thankful gratitude to Professor Atahar Ali and Professor Abdul Wadud Choudhury for giving me the opportunity to talk something in front of this learned gathering. And I can see Dr. Jamil, he has got keen interest in the field of electrophysiology. So ECG basically represents the electrical activity of the heart. The activities, those may be converted to electrical signal, only those are recognized in ECG. And to me, it appeared that there are many signals are being produced in the heart, and some of the signals are documented in the ECG machine. And the signal which has been documented in the ECG machine, our brain do not receive all the signals. Only a small part of the signal we can interpret, and which we interpret thinking that we are in right track may not be right in truly that may not be right. So if we look at this iceberg, the only small part of the iceberg is visible. Only in our open eyes, we can see the shell of the upper part of the iceberg. We do not know what are the things remains inside the core of the upper part of the iceberg that is visible.
কাদের ভাই, আপনি কি ওয়াইন গ্লাসে একটু ইয়ে দিবেন, তাহলে আরো বড় হবে।
Although thank you. So this is the iceberg. Only we can see the small part of the iceberg, and by our open eye we can see only the covering shell, and we do not know the inside. So ECG is like that, and today I thought the ECG study group should develop and should go forward and should be involved in research work to find out the unknown signal of the ECG that is being documented in electrocardiography machine. And also this study group has got the chance to document some of the signals which the ECG machine is not documenting by upgrading the ECG machine. So in introduction, just I will talk few words in the management, but the title was the what mistakes we are doing in the diagnosis of acute coronary syndrome. So acute coronary syndrome diagnosis is made by the clinical part and by enzymatic evidence. So today we will highlight what are the mistakes we are doing to interpret the ECG in a patient of acute coronary syndrome. The chief complaints of the acute coronary syndrome is the chest pain that accounts for more than 8 million of emergency department visits annually. Only a fraction will actually have a coronary syndrome. On emergency department presentation.
Please mute everyone else except the speaker. Please mute everyone else.
On emergency department presentation, fewer than half of patients with a clinical history reminiscent of acute coronary syndrome will have a truly diagnostic ECG finding. The other half will have some signs of ischemia, some non-specific ST segment and T wave changes, and some will show completely normal ECG despite having coronary artery disease, and truly it is acute coronary syndrome. So less than one, in most of the cases, we see that 1 millimeter or 2 millimeter ST elevation is significant. But when there is equal to or less than 1 millimeter ST segment elevation or depression with or without reciprocal changes, these group are actually the challenging group of patients for the diagnosis of the acute coronary syndrome. What will be the actual diagnosis and what should we do for this group of patients? An unchanged overall miss rate in acute myocardial infarction is about 2%. That is, in acute myocardial infarction, the ECG may not show any actual evidence at the initial part. So what common mistakes we are doing in the diagnosis of acute coronary syndrome by ECG? So any change, our normal interpretation is any change in single lead is normal. That is the big term in ECG interpretation. So any change in single lead is normal. But even in isolation, certain ECG findings can suggest danger. Such is true in lone T-wave inversion in AVL, known to precede an inferior myocardial infarction. That means that though we know that any change in single lead is normal, কিন্তু কিছু কিছু ক্ষেত্রে সামান্য change at a lone T-wave inversion in AVL that appears as the normal finding. We do not give attention to that part of the ECG, but it may be the signal that the patient is going to develop inferior myocardial infarction. So in every change, we have to put our attention to that. We have to interpret. Similarly, sometimes as ordinary as upright and tall T waves or biphasic T waves can be the only marker of ischemia. The tall T wave, we do not care for that. Upright T wave, where it is normally inverted like in V1. These are the findings that do not draw any attention in our interpretation system. So if there is any change like that, that may be a marker of ischemia, we have to keep it in mind in future interpretation of the ECG. And ECG abnormalities, however, subtle, should give pause and merit careful inspection, since misinterpretation occurs in 20 to 40% misdiagnosed myocardial infarction. An upright T wave in V1 is considered as normal variant. When T wave is upright and large in V1 and taller than the T wave in V6, that means there is loss of precordial T wave balance. And this is one of the features of ischemia and may help in the diagnosis of acute coronary syndrome. Biphasic T waves, an initial positive deflection followed by the terminal negativity in leads V2 and V3 is highly specific for subacute stenosis of the left antero-descending artery. This pattern is indicative of Wieland's syndrome and should consider invasive procedure, and we should avoid the provocative test in this kind of patient. We should not go for any provocative test in this patient because the patient has got subacute stenosis of the LAD, and provocative test may lead to development of acute myocardial infarction. Another important issue is posterior myocardial infarction that is missed and in many of the cases, but isolated posterior infarction occurs in lower frequency. It occurs up to 5% patients, but most of the occurs in, but majority occurs in conjunction with inferior myocardial infarction or lateral myocardial infarction. And ECG finding of the posterior myocardial infarction is very important because this is a category of ST elevated myocardial infarction, but the diagnosis is made by the ST segment depression. That is important in posterior myocardial infarction. So that is the ECG finding though there is ST depression, but we diagnose it as ST elevated posterior wall myocardial infarction. So in ECG of the posterior wall acute myocardial infarction shows the ST segment depression in V1 to V3, maybe up to V4, with tall R wave and upright T wave in V1, and the T wave in V1 is greater than T wave in V6. And if this ST elevated MI, posterior MI is in doubt, then we can do the posterior ECG leads. We can place the posterior ECG lead, that is the lead V4 to V6 in the left scapular region. And if in these three leads, if there is only 0.5 millimeter ST elevation in any one of these three leads, is diagnostic of posterior wall myocardial infarction. So posterior myocardial infarction involves a small myocardial area. So if we consider the involvement of the myocardium, it is not significant at all. But this small amount of myocardium that is involved in posterior myocardial infarction results in moderate to severe mitral regurgitation. That is an independent predictor of long-term heart failure and infarct-related mortality, and that occurs in up to 1/3 of the patient of posterior wall acute myocardial infarction. So precordial ST segment elevation due to normal variation are also challenges. I was listening the lecture of Professor Atahali about the ST segment deviation, and that discussion definitely make this understanding of these changes are very easy. So ST segment diagnosis, myocardial infarction diagnosis, normal variant ST segment elevation, and presence of left bundle branch block makes the difficulty in the diagnosis of ST elevated myocardial infarction. So in this kind of patients, we can say pseudo infarction like early repolarization, that is very clearly discussed by Professor Atahali. I'm not going to discuss in detail. And left ventricular aneurysm, if involves the inferior surface, then it can produce the ST segment elevation in the leads that mimics with acute ST segment elevated myocardial infarction. Pericarditis. Pericarditis already discussed the concavity of the upwards. In pericarditis, there is involvement of there is ST segment depression in almost all leads except AVR and V1. In AVR, there is ST depression in pericarditis, and when there is ST segment elevation in the inferior leads in pericarditis, then the diagnosis of inferior wall myocardial infarction becomes a differential diagnosis, and that is very difficult to differentiate between these two. But if we look at the ECG very carefully, we can make the diagnosis of the ST elevated inferior wall MI and pericarditis by looking at the amount of ST segment elevation in lead 2 and lead 3. In case of pericarditis, the maximum ST elevation occurs in lead 2 because the vector of pericardium is directed towards lead 2. That's why in pericarditis, there is maximum ST elevation in lead 2. But inferior surface vector is going towards the lead 3. That's why in inferior wall myocardial infarction, there is maximum ST elevation in lead 3. By this finding, we can differentiate the inferior wall ST elevated MI from pericarditis. But Sometimes this diagnosis may be difficult when the inferior myocardial infarction occurs due to circumflex coronary artery involvement, practically that involves the inferolateral surface. So in that situation, vector may be directed towards the lead 2 and maximum ST elevation may be occur in lead 2. So in such situation, by this magnitude of ST elevation, we cannot differentiate the pericarditis from ST elevated MI. So we have to carefully evaluate the patient and clinical correlation. Other diagnostic tools can help to make the differentiation of this kind of ECG. In left ventricular hypertrophy, WVW syndrome, all of you know, sometimes it gives the feature like inferior myocardial infarction. Brugada syndrome, all of you know, though I understand very minimum about the Brugada syndrome. There are some ST segment elevation in precordial leads and mimics with myocardial infarction. And left bundle branch block, the diagnosis of acute myocardial infarction may be difficult. And that can be done by different modes that we are going to discuss. Left bundle branch block, if it is new, either it is new, documented new, assumed to be new left bundle branch block, or if the pre-existing left bundle branch block with carbon concordance, then we should consider as the ST elevated myocardial infarction. Isolated posterior wall myocardial infarction, the immediate, these are the findings that demands for immediate invasive procedure with reperfusion. ST elevation in AVR, though it is not very significant, involves a single lead, and it is mostly associated with ST depression in most of the leads. That indicates the involvement of the left coronary artery or multivessel involvement or equivalent to left main coronary artery disease. This group of patients should be addressed on emergency basis. The Winter's STT wave changes, that is also important. The Winter's STT wave means there will be some ST segment depression followed by ST elevation with tall peak T wave with almost equal height of ascending and descending limb of the T waves. So this is a very important finding, suggests significant stenosis of the left antro descending artery. And hyperacute T waves already discussed. I think these are the findings on where we should go for the diagnose, go for the early reperfusion strategy in this group of patients. So with this variation that came to my notice, I am showing some ECG tracing, and all of us will discuss on this ECG tracing, and you will give me the what are the changes we are looking in this ECG. Can any learner or trainee doctor can answer? What are the ECG changes you can see in this ECG?
Systematically, anyone can raise your hand, please, volunteer.
No one?
Anyone? We have got Dr. Abida. Can you comment some? Dr. Abida.
Assalamu alaikum, sir.
Mm-hmm.
Sir, in this ECG, this is the 12-lead surface ECG, which showing that there is ST T-wave depression with STTT changes in 1 and AVL. Sir, this is the ST changes that I'm seeing. Other than that, sir, other leads they're normal, sir.
other leads appears normal. If you
Yes, sir.
do carefully to lead 2, lead 3 and AVF, you can find the ST segment appears in the normal level,
Yes,
or
sir.
the ST deviation is less than 1 millimeter. So
Yes,
this
sir.
group of patients are the challenging group of patients in our clinical practice, where there is the morphology appears as ST elevation, but its ST deviation is less than 1 millimeter. So this kind of ECG is actually the challenging. Actually আমার যে প্রেজেন্টেশনে দুইটা যদি লেখাটা না থাকতো আমি সাজাতে পারি নাই আর কি। আমার যে স্টেপ ওয়াইজ গেলে এই ইসিজি গুলো ইন্টারপ্রিটেশনটা ভালো হতো। আচ্ছা লেখা দেখেই বলো, একজন একটু বলো দেখি এটা ইসিজিতে কি আছে, লেখাটা না দেখে অনেস্টলি একটু এই ইসিজি সম্পর্কে একটা কমেন্ট করো দেখি।
Anyone volunteers from Nepal?
আমরা থিওরিটিক্যালি ডিসকাস করেছি তার মধ্যেই ইসিজি ট্রেসিংটা দেখানো হচ্ছে, যে আমরা এই ট্রেসিংটা সম্পর্কে আমরা কিন্তু ডিসকাস করেছি। তুষার কোনো ভলেন্টিয়ার আছে? লেখা আছে তারপরেও।
So again, Abida, you can comment. No problem, Abida. Welcome.
Sir, here I can see that there is that the T waves in sir lead V2 to V2 to V4, 5. It looks that there is hyperacute T, and there is also, sir, into AVF. I can see that there is some ST depression. So, sir, this may be a case of acute coronary syndrome. Maybe we can comment that it may be acute ST elevated MI. Serial ECG is required, sir, to comment.
আচ্ছা আবিদা, একটা জিনিস খেয়াল করো।
ইসিজি
Whenever
Yes,
we are talking about a hyperacute T, the
Yes, sir.
most important thing is the ST segment will not be starting from the baseline.
Yes,
It
sir.
will be started higher up.
Higher.
But here, there is ST segment depression with T wave going up and up and up very sharply.
Yes, sir.
That's not typical acute hyperacute T wave in here. This is a very typical characteristic of the winters. There will be ST segment, ST junctional depression with rapid ST segment elevation and resulting in a very tall, narrow-based T wave.
And one comment I'd like to make. All the participants, please look at the ECG and put in your mind. The reason being, sometimes we call it like upsloping ST changes. Upsloping ST changes, we call sometimes benign when you do a stress test or something like that. Normally, horizontal or downsloping is more significant. But if you understand the pathophysiology, when the coronary arteries gets occluded, thrombus forms initially. In the very beginning phase, you don't see much ST changes, ST elevation. You'll see hyperacute T wave. Because when you, anybody who works in the cath lab or cardiology fellows who is doing the heart cath, they saw that when you inflate the balloon in the coronary artery, you see that the hyperacute T waves. So this is the very initial phase of acute coronary syndrome, acute occlusion of the artery. And then, and particularly here, the ST depression there, but the hyperacuity of the T wave may tell you this patient is having acute occlusion. And if you repeat the ECG like 15, 30 minutes later, you might see the ST elevation later on this particular patient. So don't confuse with the, we call upsloping ST changes, but if the upsloping ST changes, it associates with the hyperacute T waves. Think in your mind about De Winter syndrome, and definitely clinical consideration. What's the clinical situation of the patient? You need to always look at it.
কাদের ভাই?
আমার মনে হয় যে it is very right. This is the ECG that is termed as the De Winter's T waves. This is the classic ECG of De Winter's T-wave that represents the acute occlusion of the left antero-descending artery. And very right, the changes that occurs in ECG, in my experience, I had the experience of stent thrombosis in two patients. One patient in 2009, that patient developed stent thrombosis on third day. Before discharge, on the day of discharge, she developed chest pain. ECG showed mild ST depression in lead 1 and AVL with T inversion. There is no other significant changes in the ECG. But when we took the patient to cath lab, I found the LADs totally occluded. And 2016, I found another patient. I did completed PCI at 4 o'clock. I came to my chamber. At the end of my chamber at around 10 o'clock, the doctor from CSU of lab called me that your patient developed severe chest pain with sweating, and ECG does not show any significant changes in that patient. That was a complex PCI, bifurcated lesion, LAD and diagonal branch. And so when I went there, I found only T-wave inversion in lead 1 and AVL. No other changes. That occurs few minutes. Within few minutes, I arrived to the CCU. So only changes T inversion in lead 1 and AVL. I thought that diagonal branch has been occluded. But when I took the patient to cath lab, I found the totally occluded left antero-descending artery, and that was recanalized. Now the patient is okay, and there was no significant ECG change after second procedure of that patient. So in the early phase of the acute coronary syndrome, the ECG changes basically maybe misguided. Last night, I had one patient in my chamber. Age is 32 years, a liver donor to his mother. Came to me with chest pain, told me that I experienced chest pain last night. Late part of the night, I had chest pain. And sometimes I'm getting chest pain, but no relation with exertion. I asked him how much you can walk. Well, I can walk for up to 1 hour without any symptom. So naturally, I thought it is not a acute case of acute coronary syndrome, and ECG was absolutely normal. Normotensive, non-diabetic. Only factor was that he was maintaining stressful life after liver donation. And his mother also died during the liver transplantation. So that was the frustrating part, stress. Otherwise, he had no significant risk factor. Last night at 3 o'clock, I got a call from Labit that the patient admitted with acute anterior myocardial, ST elevated anterior myocardial infarction. So this kind of patients, sometimes the clinical presentation as well as the ECG finding, both may be misleading. And in this ECG, this is a very different morphology from the hyperacute T-wave and different morphology from ST elevated myocardial infarction. Here, there is ST segment depression at the initial part of the depolarization, followed by the ST elevation, merges with the T-wave with almost equal limb, ascending and descending limb of the T-wave is almost equal. That is present from V2 to V3, V4, up to V4, it can present. So it is a classic feature, and it is the representation of the acute occlusion of the left anterior descending artery. Anyone can pass comment on this ECG?
Sir, may I try, please?
Yeah, please.
Sir, here in this 12-lead surface ECG is showing there is ST elevation in lead AVR, and there is the ST depression in the lead, all the leads, like more than 8 leads, both chest and limb leads. So it may be a case of acute equivalent to acute ST elevated myocardial infarction.
It is not equivalent to ST elevated myocardial infarction. This is a very classic. Sometimes we tell it as forgotten lead. It is the forgotten lead, that is the AVR. If you look at the ECG, most of the leads shows ST depression, except AVR and V1. There is ST segment elevation prominent in the AVR and also mild ST elevation in V1. So in such situation, we calculate the elevation of the AVR is higher than the V1, and this kind of ST depression represents, what does it represent?
So
We
left
discussed it
main-
earlier. Probably it involves the left main or left main equivalent lesion. It is not the ST elevated myocardial infarction. It is the representation of
left main equivalence.
left main or left main equivalent lesion. That's why there is ST depression in lead 1, lead 2, lead 3, AVF, and also ST depression from V3 to V6. So most of the leads, there is ST depression, only mild ST elevation in V1 and ST elevation in AVR. This is one of the classic ECG finding of acute coronary syndrome. Anyone in this ECG actually, I mean, I could put the statement later on. But anyway, even with this statement, anyone can put any decision on this ECG. Any comment?
Sir,
Acha, sir.
sir, many a times that STT changes in lead V1, V2 makes us confused, or the juniors, those who juniors like us or mid-level, get confused with this ST depression. Sir, just if there is chest pain and ST depression in V1, V2 with upright T, can we straightway comment posterior myocardial infarction without involvement the 2-3 AVF?
You can say it, because if you look at the statement that I discussed, the posterior wall myocardial infarction isolated frequency is low, up to 5%, and posterior myocardial 95% occurs in association with inferior wall myocardial infarction or inferolateral infarction. So if there is ST segment depression in V2, V3, or sometimes it may be V4, associated upright T wave in V2, V3, and this T wave, if it is greater than the T wave in the V6, that is a strong suspicion for the diagnosis of posterior wall myocardial infarction, isolated posterior wall myocardial infarction. But if you doubt in the diagnosis in such cases, you will put V4, V5, and V6 lead in the left scapular area. And if there is ST segment elevation up to 0.5 millimeter in any one lead, not 3 lead, any one lead, if show ST segment elevation up to 0.5 millimeter, that is diagnostic, that is the confirmatory ECG finding for posterior wall myocardial infarction. So this kind of ECG represents the true posterior infarction.
Kadir. Hello, Kadir.
জি জি বলেন।
As a Professor Abdul Chaudhary is a master of this kind of the ECG. My
Posterior-
question is,
রাইট।
Chaudhary is a master of posterior. Professor Kadir, does this patient fulfill the criteria of thrombolytics? This patient?
Yes. Yes, this is one of
This
the
is not
situation.
only
You follow the guideline, they will say this is the situation where you can go for thrombolysis.
And also to prove that point, definitely you can do the posterior ECG, see the
Yes.
ST elevation, do it. Yes.
This is one of the indication for the early reperfusion therapy. We have to consider যে কতগুলো প্যারামিটার আছে তার মধ্যে this is one of the parameter. যে এইটা ইনভেসিভ মানে এটা রিপারফিউশন করতে হবে. Whatever the mode of reperfusion, maybe thrombolytics, maybe invasive, anyway.
So which artery is commonly involved this kind of the ECG, Kadir?
অদূর চৌধুরী
স্যার এটা সার্কামফ্লেক্সে সাধারণত পাবে,
সার্কামফ্লেক্সের ওয়েন ব্রাঞ্চ থেকে
কারণ আইসোলেটেড পোস্টেরিয়র এমআই without involving the inferior leads is very unlikely in case of
in up to 5%.
left dominant right dominant system, very rare. But in case of left dominant system, it involves the circumflex posterolateral artery, posterior ventricular artery. That's very important. The most important thing already been said. You have said it, because it supplies the posterior medial papillary muscle dysfunction that leads to MR, and so acute inferior MI with posterior involvement, posterior extension is bad. Acute posterior MI in isolation is also bad because of the presence of MR, and that leads to more chance of LVF and LV dysfunction.
Right. So we have to look at this very carefully in a patient of inferior and inferolateral myocardial infarction to identify the posterior. মাঝে মাঝে অদূদের উপরে করতে অদূদা তো পোস্টেরিয়র উপরে এত ইন্টারেস্ট তার কেন? দেখলাম যে দিস ইজ এ স্মল টেরিটরি বাট ইট ইজ এ ইম্পর্টেন্ট পার্ট দ্যাট ড্রজ আওয়ার অ্যাটেনশন।
Yes.
এটা আমাদের খুবই ইম্পর্টেন্ট একটা ইসিজি ফাইন্ডিং, পোস্টেরিয়র ওয়ালকে আমাদের খুব অ্যাড্রেস করতে হবে। দিস ইসিজি এটা আর মনে হয় যে সিম্পল হয়ে যাচ্ছে, আর ডিসকাশনই যায় না।
স্যার এই আগেরটা একটু যাবেন। Whenever you are in doubt that the ST elevation we are seeing in inferior lead is important or not, look at the ST depression in AVL. If it is present, this is very likely to be a real acute ST elevated inferior eye.
That is
The
the
reciprocal
message
change
it
is the key to your proper diagnosis. Adis bhai.
Now, I totally agree with that because reason is you can see if you look carefully, look at that lead 3 AVF. There's question about how the ST look like. Okay, and also if they coexist with TUV inversion, ST depression, TUV inversion, AVL, one in AVL particularly, you need to be more serious. And if you have any questions, sometimes definitely clinical scenario is there. You have to always take into account. But in this situation, if you have, normally, I think this is good enough for me to diagnose acute event, okay? But if you have doubt, repeat the ECG in 15 minutes later, you'll see a difference in this patient. Possibly, okay?
Sir,
But
sir, there is a question that
mhm.
presence of ST depression, is it a must or is it related anyway to prognosis?
Depends on what is the ST depression.
Reciprocal, the reciprocal changes, ST depression, the reciprocal ST depression that we often classically said that in case of anterior MI, there will be reciprocal changes in inferior leads, and in case of inferior MI, there will be reciprocal changes in anterior leads. Is it a necessary? Is it a must?
It's not is not a must, but we expect that, but according to the position of the electrodes that we have in anterior posterior area. Okay, if it is there, it confirms your diagnosis more, and it also probably reflects the myocardium in jeopardy, how much myocardium in jeopardy. Okay, that can define that area that you're seeing some reciprocal changes. But I don't think it's a must.
Yeah, it's not a must, but it always helps to determine whether it's actual or not. And one thing is that whenever you are not sure, say patient is giving a history of chest pain for last 24 hour, but you are getting reciprocal change. Actually, the patient was having unstable angina that has resulted in recent acute MI, acute ST-limited MI. And probably the patient is in the zone of thrombolysis. That helps. Reciprocal change do not last too much. If it is there, that means the patient in our country, because we do not have primary PCI, you can give thrombolysis to this patient.
So there is a question in the chat box that is there reciprocal change due to ischemia or only because of the lead position?
That's a difficult question thing to answer, because even the experts are not very sure which way to go.
And another thing that we need to understand, sometimes it complicates how the anatomy of the artery. Okay, as for example, like if you're LAD, we expect that anterior ST elevation occlusion and inferior probably depression. You might expect that, but if the LAD is way big enough, wrap around LAD, that will definitely complicate the scenario. So you might not see that classic reciprocal change that you expect. Rather, you see some sort of elevation in that area because it's supplying that apical, even going to the part of the inferior area if it's a big LAD. Or if it's a right coronary artery is huge, wrap around and going to the little part of the anterior area, that can also complicate that. So it depends on the anatomy, and also depends on the how much blockage you have in other arteries. Okay, so they might have a coexistent blockage in other arteries, like 60%, 70% blockage. They might be getting, if they have dominant artery going to that area and right coronary artery has some 70% disease, that will complicate also the classic picture that we expect. Yes, there's always exception because of those reasons. But in a normal way, you expect that, but you don't expect to see them all the time. Yes, that is correct.
কাদের ভাই আপনার ছোট্ট একটা এসিজি অনেক ডিসকাশন করে দিল আপনি আগান
reciprocal change basically in past when we were student the reciprocal change was considered as a simple that may be due to placement of the leads, but nowadays the reciprocal change does not mean that it is the similar as with or without reciprocal change. When there is any reciprocal changes, that indicates the more extensive disease, and there is chance of involvement of the multivessel rather than single vessel. This ECG
Tushar, any volunteer or you? Either volunteer or Tushar, you. Very difficult ECG, very minimal sense, Kader.
এটাই যে আমাদের জন্য এটা খুবই ডিফিকাল্ট হয়ে যায় sometimes we miss the diagnosis and at a glance it appears as the normal ECG, but
very minimal change. Yeah, very
minimal change. That is the T wave in V1 is upright, broad, and this T wave is larger than the T wave in V6. So this is one of the evidence of ischemia. So this kind of patient, if presents with chest pain suggestive of acute coronary syndrome, should be considered it as acute coronary syndrome. If the T wave is upright in V1, V2, and taller than the V6, that is one of the important findings.
That is in presence of the symptom upright T1, that is the T in V1, that is taller
V1,
than the
V2
V6.
upright T wave is considered as pathological. If there is symptom, definitely it should be considered pathological. But we have to compare the T wave in V1 with the T wave in V6. Normally, the T wave is taller in V6 than in V1, V2. Normal patients, the T wave is inverted.
Whether this changes even comes earlier than the enzyme, Kadir, this kind of the minimal
Only
change.
this represents that it is the evidence of ischemia. And I do not know the comparative study with other changes, whether it precedes the development of the ST segment elevation or not. That is not mentioned. It did not come to my notice. But this is the change that we have to consider as a case of acute coronary syndrome, and we have to treat the patient accordingly.
So what you are saying that we do not expect a very good, beautiful T wave in V1 normally.
Right.
But if it is there, we have to pay attention.
We have to give attention.
Pay
That is
attention.
important.
Look
That
at
is
the clinical scenario, look at the other ECGs, look at the reciprocal changes, and then give a decision.
Right.
And I'd like to make a comment. This WKG that makes us difficult in the emergency room to decide what way to go. That is absolutely correct. So when a patient comes with chest pain in the emergency room, you have to really think about what's the pretest probability of acute coronary syndrome in this patient, okay? And look at the scenario, you know, the TME13 criteria or, you know, some other criteria to define that, what's the pretest probability of acute coronary syndrome. ECG is one of the factor, not the only factor, okay? You have to look at the clinical scenario, you have to do the exam, whether there's any new heart murmur or anything going on. Definitely then ECG comes into role. And then the heart enzymes comes into role. But heart enzymes always delayed, you know, if it's acute situation, it might delay 2 hours or 3 hours to get the results back. But the question right now, that if the pretest probability is high, then this WKG should bother you. Do not let the patient go, okay? That's the clinical scenario is extremely important. That I'd like to make sure that our all trainees keep in mind. Because if this patient comes to me with this ECG, you know, just only the ECG, definitely I'll not say that something like we have to take him to the cath lab right now, unless I know the clinical scenario, what's going on with the patient, what's the pretest likelihood the patient having true acute coronary syndrome. So don't miss the clinic, okay? And also, yes?
I want to add that if you get such an ECG, ask for any previous ECG available. That will help you to compare with the previous ECG, whether this is a new change. That will also help you.
Beautiful ECG.
Always we can compare the ECG with past one. That helps us in making the diagnosis. What are the new changes? That is very important. And clinical judgment is also important in every patient, in every case. Next question to anyone. This is
That's
a
good,
very
EKG.
massive ECG. Sometimes we are getting in our practice as well. I am afraid of this kind of ECG. It becomes difficult to make the diagnosis. Sometimes decision may be difficult. This kind of ECG change will persist for days together. Anyone?
Mr. Sushanta Borua has raised hand.
Yeah, welcome.
Amul bhai, can you make him panelist so that he can speak?
Sushanto Borua. Tushar.
হ্যাঁ রিভু,
আর কেউ বলার?
so before that Kader, আচ্ছা, whether this kind of ECG can present without symptom?
Without symptom, anyone can present without symptom because some patients develop silent myocardial infarction. So in those group of patients where there is loss of pain perception, those group of patient might present without chest pain. Otherwise, this is the patient will present with chest pain, typical chest pain of acute coronary syndrome.
আচ্ছা, if there is no facilities for the cath lab, whether this patient fit for the thrombolytics?
Actually, if there is no facilities for the cath lab, then we have to go for the standard medical management rather than thrombolytic therapy. Because this is the finding that represents. Tushar ki bolte parben, what does it represents? This ECG?
This is very specific for proximal LAD involvement.
Tushar, Abida ki bolte parben kisu?
Sir, here I can see, sir, in lead V2 and V3. So the T wave, there is STT changes. The T wave looks biphasic T wave, which is typical of Wieland's syndrome.
Yeah.
আপনার প্রশ্ন যেটা আসছে আবিদা ওইটুকু বলেন যে এখানে ক্যাথল্যাব নাই, তাহলে এই ইসিজিটাতে আমাদের দুইটা জিনিস আপনার চিন্তা করতে হবে। ক্যান উই গো ফর thrombolytics? That
No,
is
sir.
one of the question that is asked by the.
No, sir, we cannot go for the
Why
thrombolytics.
you will not go for thrombolytic therapy in such patient?
So because, sir, here I can see there is biphasic T wave, but without, sir, actually there is no clear-cut ST elevation or in any way.
Actually, in this ECG, termed as the Wieland syndrome, biphasic T waves occurs in V2, V3, sometimes V4. If you look at the ECG, they are upright T followed by the downsloping. This is the biphasic T wave. Some people might consider it as E wave, maybe confused with E wave, but it is not E wave. It is the upsloping T followed by downsloping, up and down. So both slope is there and minimal ST segment elevation. This is the evidence of subacute occlusion of the left antrodescending artery. In subacute occlusion, we never use thrombolytics. So it is
That is
in
correct.
ST elevated MI or unstable angina equivalent. We cannot use thrombolytics here. It is subacute occlusion. And this is the ECG where you should not go for stress evaluation.
Yes.
You should not go for stress evaluation. That is contraindicated.
This is very important.
That is very important.
That's very
This
important.
kind of ECG, if you find in your life, do not go for any stress evaluation. That is contraindicated.
Actually, this is the change with in the scenario. They need invasive procedure as early as possible.
Right.
Please do not send the patient for ETT. Do not do that.
So I think I covered the one side of the visible iceberg, and lot of things
True, true.
remain beyond my vision. The what mistakes we are doing in our practice, I just focused on some of the EKG where we might miss the diagnosis that came to my notice. I discussed on that. Lot of mistakes we are doing in every day. especially when the ECG is normal in a patient with suspected acute coronary syndrome. That is the most important mistake we are doing everyday practice. And at the end of my lecture, my conclusive appeal to the ECG study group is to concentrate the study of ECG in our population to discover something from the ECG recording. I think lot of things in ECG is unknown to us. We cannot receive the ECG signal in our brain. So this ECG study group is our hope that in future we will be able to get some new information from our study group and the nation will be benefited. Thank you, everyone.